All right, good morning, everyone. Thank you for your patience. My name is Robert Hersey. Happy Thursday and happy leap day to each of you. And on behalf of the Florida Alcohol and Drug Abuse Association, welcome to today's webinar entitled Florida's Recovery Residences, Tracing the Journey, Evaluating the Impact, and Envisioning Tomorrow. This webinar is being made available through a collaboration of the Florida Department of Children and Families and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in listen-only mode and are only able to view your name. Your webcam and microphone have been intentionally disabled. If you have questions during today's webinar, please send them to the presenter and me, the host, FATA Webinars, by using the chat panel. The button to open the panel is usually located on the upper right side of your monitor. Please use the chat panel to send any questions you may have as you think of them. The presenter will address questions as time permits. Our audio is broadcast through the internet to your computer. If you experience poor computer audio at any time during today's presentation, there are a few options to try using the Communicate menu. One of these options is on the screen now, and all options are posted at the very top of the chat panel as well. After ensuring that your volume, both on your computer and external speakers, if applicable, is not lowered, click the Communicate menu, then click the Audio Connection panel. Click Disconnect. Follow the first two steps again, and then click Call in using a computer and follow the instructions. If you continue to experience poor audio through your computer, try using the I Will Call In option under the Communicate menu. The access code and event password are on your screen and again at the top of the chat panel. You must be connected to the audio of this presentation and view it on screen to receive a statement of completion. We are unable to verify attendance if you are not connected to WebEx via your computer or mobile device. Therefore, audio-only attendees will not be eligible for a statement of completion or CEUs. The recording and materials used in today's presentation will be available on the FATA website within 30 business days. To access the recording and PowerPoint, visit www.fata.org, navigate to the Resource Center, and click on Training Library as shown on the screen. FATA produces many webinars and workshops through the support of the Florida Department of Children and Families. To help participants track credits earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credit for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct you to an evaluation form on the FATA website. You will first need to register or sign into your account to complete the evaluation. Please ensure that your name and your email address match what you provided when you registered for today's webinar. Information you provide FATA as part of registering remains confidential. Statements of credit will be posted within 30 business days after the evaluation closes in individual professional development journals for persons completing the evaluation and attending the entire webinar. Completing the evaluation is necessary to receive CE credits or to access your statement of credit. Please note that the evaluation will close at the end of the day on Tuesday, March 5th, 2024. We encourage you to complete the survey as soon as possible. If you experience technical difficulties accessing the survey or have a question about your account, please fill out a contact form at www.fata.org or email training@FloridaBHA before the evaluation closes. Up to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you are a licensed healthcare practitioner, be sure to include your Florida license number and prefix for reporting to CE Broker when you register with our site for the first time. If you are certified with the Florida Certification Board or licensed outside the state of Florida, you do not need to provide your certification number when you register with our site. Please note that WebEx monitors the arrival and departure times of attendees and provides a report upon completion of the event. We are not permitted to provide a statement of completion if you do not attend the entire webinar, and we are not permitted to provide partial CE credit. This presentation is intended solely for educational purposes. The views, opinions, information, and content expressed in the presentation are those of the presenter and do not necessarily reflect the views, opinions, or policies of the state of Florida, the Florida Department of Children and Families, the Florida Alcohol and Drug Abuse Association, or the Florida Behavioral Health Association. Attendees should note that sessions are recorded and published in various media. Our presenter today will be Michael McKeogh. Michael is a dedicated professional serving as the regional manager for Oxford House Inc. in Florida. He is also a nationally certified peer recovery support specialist. Michael has built an impressive career with Oxford House and has worked tirelessly in various states, including Louisiana, Mississippi, Alabama, and Florida. From the inception of the Oxford House project in Florida, Michael has been an integral part of the organization's mission to provide safe and supportive environments for individuals in recovery. His expertise and unwavering commitment have contributed to the success and growth of Oxford House in Florida. And now, Michael, I will turn it over to you.
Thank you, Robert. Good morning, everybody. As Robert just said, I am the regional manager for Oxford House in Florida. I'm also a person in long-term recovery, and what that means for me is I've not found it necessary to drink or use any drugs since July 15th of 2016. And so that will carry me into today. I want to go over recovery housing in Florida across the board. The recovery housing best practices put out by SAMHSA last September. Oxford houses in general, and just the concept and the model of what that looks like. The NAR affiliate here in the state of Florida being FAR, Florida Alliance for Recovery Residents. Some of the laws regarding recovery housing in the state, and we'll speak a little bit about what some legislation upcoming might look like for the future, specifically pertaining to medications for opioid use disorder. And so, yeah. All right, so we're going to start off with the best practices put out by SAMHSA last year. This really revolves around what they have identified, what stakeholders, what states, legislators should be looking at to identify, to be able to give guidance and put in ways for the state or the municipality to be able to guide operators throughout the state to make sure that recovery housing is doing a good job at helping people, recover long term. And so some of the learning objectives: obtain a thorough understanding of current best practices for recovery housing, gain insight into how medications for opioid use disorder are complemented by the support of recovery housing, achieve working knowledge of how Oxford houses and FAR certified residents operate, including levels of support. So here's the SAMHSA best practices. And so back in 2023, President Biden signed the Consolidated Appropriations Act, and Section 1232 in that mandates the development and publication of recovery housing best practices. And so that's what SAMHSA has done in this. On SAMHSA's website, if you go to their homepage, go to Programs, Evidence-Based Practice Resource Center, and then under that, Best Practices for Recovery Housing. And so it's an updated version from 2018. And so you might have to go back a few pages in order to find it. Also, I think Robert is going to be able to make that available for anybody that wants it, as far as the material that we're going over today. On some good information. Document updates prior to recovery housing guidelines for state providers, operators, and stakeholders. Emphasizes housing as a vital dimension supporting recovery, aligning with SAMHSA's recovery definition. And so the definition that SAMHSA has put out for recovery defines recovery as a process of change through which individuals improve their health and wellness, live self-directed lives, and strive to reach their full potential. It's a pretty broad definition, but recovery can be a pretty broad thing. And so it's encompassing of all those different aspects. All right, so the recovery housing best practices really highlights the critical role of recovery housing in supporting individuals on their recovery journey. Research-backed positive outcomes, decreased substance use, lower relapse rate, reduction in incarceration, higher income, increased employment, and improved family relationships. And so this is where that research comes from, and we'll go into that a little bit deeper. Recovery housing as a recovery support service designed by people in recovery. Social model recovery principles underpin the setting, fostering pro-social bonds, community, and recovery support and supportive environment. The community pro-social bonds aspect of recovery housing is something that we'll really kind of tie into today, and it's really what makes recovery housing successful. It provides the ability for an individual that has relied on drugs and alcohol for so long to be able to be an individual that feels comfortable in their own skin. And now, without those things, learning how to act and learning how to interact with individuals can become very difficult. And so by being in an environment, a group environment, where you're basically forced to interact with individuals on a daily basis, instead of isolating, which leads to depression, which leads to so many other detrimental things, having that group, that peer-to-peer group living with you has so many benefits that we'll kind of highlight. All right, so the recovery housing best practices goes through a little bit of history. Back in the 1830s is when sober living homes really kind of started with the Salvation Army and YMCA. They were really kind of religious based back then, and it was something that you had just leaders in the community that saw issues with things going on with people with alcoholism, and they wanted to be able to create an environment, but it was centered around religious practices. That kind of grew from the 1800s into the mid 1900s into the AA really like taking charge, and the development of a lot of 12-step houses. They were mainly out in California at that time, and they developed and were successful and really just coincided directly with Alcoholics Anonymous. And you see a lot of things with the temperance movement at the time, where individuals and kind of religious organizations again really tried to set things in place to help individuals, but also really focus on that religious aspect. And then as things progress, the development of just sober living homes, recovery housing, that kind of progressed with more common practices, a more liberal approach, a progressive approach to recovery, not just being religious focused or only AA focused, until we get to today where it's really just about recovery. And also, as we have gone through this opioid epidemic in this country, and SAMHSA has the strategic opioid response grant, they've been able to really implement funds for various state entities to be able to successfully bring about recovery housing or help supplement the cost of recovery housing to individuals, depending on where they're at. It's a very difficult thing to be able to provide that amount of funds to so many people across the country that are dealing with this opioid epidemic, and even just other drugs as well. But I'd say that the strategic opioid response, the state opioid response grant funds have been able to help a tremendous amount of people, and they continue to do so. And they continue to progress in their ideas of what that looks like and how they're able to deal specifically with people with uh, opioid use disorder and supporting individuals on medications for opioid use disorder and recovery housing, things of that nature. So here we have the national lines for recovery residences, 4 levels of support. And this is translated also to their affiliates. Um, the affiliate here in Florida is FAR. I'm sure many of you have heard of it. Um, their levels might differ a little bit, but they're going to stay pretty much the same as far as what is kind of outlined here. But there might be a subtle few differences in what you're looking at, specifics of maybe a peer-to-peer service or a level 1 recovery house and whatnot. So back in 1975, Oxford House opened its first recovery home, um, and that was what NAR now equates to a level 1. It is a self-run, self-supported recovery home. It's run on democratic principles. It offers the peer-to-peer support. There is no paid staff living in the houses with the individuals. It is run democratically by the members that live in the homes themselves. And I'll get into the Oxford House model more deeply as we get further in this. But this is what level 1 has really been identified as under NAR. Level 2 is something that prior to Oxford House in Florida, something that was the main recovery housing organization, the recovery housing entity in the state of Florida and throughout the country. It's basically the sober living home that has a house manager, a live-in house manager, usually more of a seasoned member of that house, a resident that is kind of promoted, so to speak, into a manager's role. And they'll work with the owner or the operator to make sure that the guidelines are being followed and the rules are being followed and people are doing what they're supposed to be doing and working recovery programs and things of that nature. Excuse me. Level 3 is going to be much like level 2, but it will have usually a certified peer aspect to it. And so there might be certified peers that come to the house. There might be that house manager might be a certified peer. It's going to have some aspect of that peer support in the kind of sense that that individual is a peer specialist. And so they'll have that kind of embedded in their program to where individuals are meeting with that peer on a weekly basis or what have you, to really get those peer services that they might not get in the level 2 or level 1 without going out into the community. In both of these instances, individuals are are able to go out. They're able to continue doing outpatient services and um, counseling and all those things. But this is just within the house. And then your level 4 is going to be your basically so it is it's a type of treatment that do need to be licensed in the state of Florida as a treatment. It is much higher level of care compared to level 1. Um, and it's a clinical setting. You have clinical staff. You have not necessarily clinicians living in the house, but they're going to be coming there regularly to meet with the members, to meet with the clients at that point, and to make sure that um, they're receiving the treatment that they need. And so it's I'm not exactly sure of all the insurance-based stuff on that, but it's billable to insurance and it's different than the other 3. All right, so the overview of recovery residence levels. So self-identify in recovery. And so individuals living in Oxford House must identify that they are in recovery from either alcoholism or drug addiction, substance use. And so that's the basic requirement to live in an Oxford House. They have the peer community built in with accountability. There's no on-site paid staff, although there are outreach coordinators that work with the houses on a regular basis in the state of Florida. They're able to provide guidance and support and training and things of that nature to really work with the houses. And then they're democratically run. And so the democratic basis of Oxford House is really kind of its foundation. It allows everybody in the house to have a voice. It allows everybody to feel heard and encourages participation. There are on-site peer support, so the other members in the house mutually support each other. And with this democratic basis, that foundation, it really spurs on the peer-to-peer aspect of Oxford House. It encourages leadership. It encourages people to want to be of service and to help. And we'll get more into kind of the service structure of what Oxford House looks like. It's pretty extensive and it's pretty amazing of where it's at today. As I was talking about before, so many individuals living in Oxford House participate in outpatient services, do one-on-one counseling, uh, go to doctor visits, participate in medication-assisted treatment or medication for opioid use disorder, and so that's very, very common. The level 2, again, so this is your kind of house manager. Stable recovery seeks a more structured and supportive living environment. And so they're not going to have the kind of just ability to democratically choose how to do things. It's going to be more set in stone. There's going to be that house manager that is going to be the authority in the house, and they're going to be the individual that really makes sure that people are doing what they're supposed to be doing, as opposed to the group accountability. Um, and so a lot of times this individual is just a member that is kind of promoted, and in turn they'll either get a small amount of pay or a free stay. And so it might be a weekly amount that they don't have to pay anymore. And so that's kind of, they're still able to go out and work a job and do what they need to do in order to progress in their recovery. But it's just kind of a discounted rate. So in a lot of these circumstances, and the level 2 can kind of be broad, how it specifically operate, but generally residents will participate in the governance somewhat with the staff and the operator. There'll be accountability with that, but not as much as you might see in the democratic environment of Oxford House. It'd be more on the house manager. Community house meetings, peer recovery support, on outside mutual aid support groups. So again, they'd go out and participate in outpatient services and things of those natures. So your level 3, so the moderately structured daily life, those seeking moderately structured daily schedule and life skills support. There's a paid house manager, administrative support, and then the peer aspect of this. And this is what really differentiates it from the level 2. The certified peer recovery support service provider would come into the house. And so those services would be provided to the individuals that live there on a continuous basis. Okay. So your level 4, again, so the therapeutic community, it's really a clinical setting, but it does it in a way where it is a much smaller, closer knit environment. You might have more of a group therapy kind of aspect to it, and you're going to have the paid and licensed staff come in and really be able to provide counseling and treatment. And so I think that all of these levels are very valuable. That being able to have a kind of range to pick from, being able to look at, well, I'm not ready to go to an Oxford house or live on my own, but maybe I'm ready to go to a place that has direct services, and maybe step down from that in the future. And so there's a range, and I think that uh, the range is good. The being able to provide um, a way for somebody that might not be ready for something to kind of step down out of residential care into a different kind of setting, a more in the community feeling, a more progressed feeling. So I've accomplished something, I'm going on to the next step. And it's a good feeling and encouraging and provides hope to those individuals. Some of the research that's been done. So Oxford House residents had a lower substance use rate at 31.3% versus 64.8%. And so this was a study done with, I think, a few hundred individuals in the Chicago area. It was done in the 90s, I believe. We can fact check that. But they looked at really, so they sent a bunch of people to Oxford House and they sent a bunch of people out of treatment to just usual care. And so whatever that looks like, there's outpatient services, therapy, whatever have you. But they were participating in usual care. And so that study really indicated that having that supportive environment of living in an Oxford House long term really translated into much lower substance use rate, almost one third less. And so or more than one third less. And so that's really a tremendous thing to be able to see, of just being able to transition from a residential care or incarceration facility, to be able to live in a supportive environment, to be able to live in an accountable environment where there's other individuals in recovery that are going to help you progress in your recovery. Also, the income thing. I think just the accountability in Oxford House to become self-supporting individually, and to want to do better and to want to be able to progress and take care of myself and not be reliant upon family or even the government. Um, just that kind of outlook really encourages individuals to seek out employment, but seek out good employment, and to be good at their job so they're able to maintain that and progress with that. So the economic benefit, because of the structure of Oxford House, because it is self-run, self-supporting, um, there's no cost to taxpayers for the individual Oxford House. Um, so the individual that is now staying um, substance use free for longer than the people that received usual care now translate into a pretty large cost savings, millions of dollars across the country, um, to not go to detox, to not go to treatment facilities, to not go to jail. And so it just translates into a large cost savings for the taxpayers in the area. So you're level two, and so the kind of colloquial term for level two is the California sober living. Um, and we'll talk a little bit about this when we get to our best practices. But the issues that Florida, California, and now many other states have had in the past, with recovery housing and the what's called body brokering, really spurred from this kind of environment. Um, Now today in Florida, that has been all but eliminated. And they're doing a tremendous job. FAR is doing a tremendous job the state with enacting certain laws as being able to do that. But this was something that was abused very widely in the past, where these operators were working in conjunction with shady treatment facilities and doing a lot of very negative things to hurt individuals in order to just continue billing their insurance. And so now with the implementation of the certifying body, which is FAR in the state of Florida, there's much more oversight and accountability that comes to recovery housing in the state. And so we see a lot of these, and I'd say probably the majority in the state are level 2 and 3. That are doing tremendously well. And so when you hear California sober living, don't automatically think, oh, this is a bad actor and this is a bad place, because it's not nowadays. In the past, there would have absolutely been reason for concern. Okay. So your level 3, really emphasizes resident leadership and governance with mutual aid, the non-clinical support, the peer support specialist. SAMHSA did a study a while ago, really showing the effectiveness of peer support services, peer recovery support services, and how effective it can be, and how cost effective it can be to be able to send somebody to work with a peer specialist. Myself being a nationally certified peer recovery specialist, in going through that training and being able to work with individuals and understanding the best practices there, just anecdotally, I can tell you that the peer services or the peer ability to work with that individual one-on-one is unparalleled. If I'm able to sit down with an individual and talk about my own personal history and how I've gone through this, and now today I'm talking to this individual that's going through a very similar circumstance, and they see me, and they see the successes that I've had in my recovery. It gives them hope, and it gives them some guidance, and even can give them a framework of what to try to do in order to get better and to recover and to live a life worth living. And so this is an amazing thing to be able to provide in-house and to be able to give to individuals on a daily, weekly, however often basis, continuous basis. It's definitely something that is very needed and should continue. Your therapeutic communities. So therapeutic communities have been studied for many, many years, and the effectiveness on those. They really started out with this kind of idea back several decades ago that we're going to sit individuals down and kind of berate their behavior and talk poorly to them and really hold them accountable, and really show them what they've done wrong. And it was done in this kind of group setting where like your peers were supposed to talk about the things you did in a way that probably would feel really bad about after that conversation. That's translated today, or that's changed today, into a much more supportive environment. And there's still much of that group therapy going on, but it's not in that aspect. It's not in that kind of line of thought anymore. And they're really focused on helping people to recover and doing it in a positive and hopeful way. And so the clinical support that are there and the staff that are there to be able to help those individuals in that more inclusive environment, in that smaller environment in-house. In my mind, of course, I've never experienced this, might be a little bit better than direct residential treatment. I could be wrong, but I think that having that more close and tight-knit group I would say at a minimum, it's absolutely a great way to step down out of residential treatment. Okay, so some of the kind of concerns in the past, the inconsistency in quality among recovery residences. And so in Florida, I'm sure many of you have heard in probably in the past decade is when they've really started cleaning a lot of stuff up. Um, but it wasn't even just the aspect of the fraudulent insurance practices and working with those bad actors. But it was just a lot of people that had homes that they were renting out and they didn't care or they didn't know anything about recovery. And you had an environment that was just conducive to continued drug use. Because it was just an environment where you paid your rent and you could stay, but it was called a sober living. And so now today, with the certifying body with FAR and with Oxford House, there's accountability in place and there's best practices being followed, so that um, all the certified or chartered recovery homes in the state are held to a much higher standard. There's still some uncertified houses out there, and what that looks like, I don't really know. Um, but it's something that the state of Florida has done tremendous at being able to bring those people in, bring them in to get certified, and now being able to hold them accountable and have just some checks and balances in place. And so these best practices that SAMHSA has put out are really pointed at the policymakers throughout the states. And I think Florida has done a really good job at really kind of looking at the trends and looking at the way things are going and implementing basically all of these practices prior to this report coming out. And so Florida has definitely done a tremendous job with that, with the abilities to kind of identify things that need to that they needed to make sure happen throughout the state in order to provide safe places, effective places, and just quality places for people to recover in. And so the national organizations, this is talking about that played a crucial role in shaping recovery housing. So that's going to be Oxford House and the National Alliance for Recovery Residences. There might be a few other outliers out there that have done some things to help implement, but SAMHSA has really worked strongly with NAR and Oxford House to um, really get the basis, I'd say, for this best practices, and really kind of implement the growth of these practices. Because I mean, these things are a lot of these practices are things that Oxford House has been working on for many years. And so we continue to do so and continue to get better and to make sure that we're providing healthy environments for individuals. So I'm going to go through the best practices one by one. There's some really tremendous things to be able to look at, especially if it's a new organization that's trying to start recovery housing, if it's a state that's trying to kind of outline what recovery housing should look like. Just really just solid things that should be in place in any kind of recovery housing environment. So be recovery centered. I think that goes without saying. Emphasis on recovery focused approach in housing operations. And so I don't think that um, that you could call yourself a recovery housing organization or a recovery housing entity without being recovery centered. It's just it's so important to be able to work with the membership that you serve, to work with the individuals that are transitioning out of treatment facilities or out of jail, to be able to just grow in their recovery, and to be able to encourage that and to help individuals. Okay. All right. Promote person-centered, individualized, strengths-based approaches. Tailor support to individual needs, strengths, and preferences. And so this has a lot to do with just meeting people where they're at, looking at recovery as a very broad spectrum and not putting people into a box, not saying that Alcoholics Anonymous is the only way. And as a member of Alcoholics Anonymous, I can say that I support all pathways of recovery. That an individual might not hear the message of recovery, find the hope of recovery in a certain program, and that's okay because they can find it somewhere else. The recovery housing kind of environment should really promote that and should encourage that, and just hold the individual accountable to that recovery program, whatever that might be. It also, so this individualized person-centered approach can really look at the medications that individuals are on. So the medications for opioid use disorder, and again, meeting somebody where they're at. And so if this is a medication that's going to help them in the recovery, it's going to keep them alive and help them to not return to active use. It's an amazing thing. And to keep somebody alive for long enough to where they can get to a point where they're comfortable in their recovery and just grow. Incorporate the principles of the social model approach. Apply social model principles for holistic recovery environment. And so really creating a community and creating the environment for individuals to want to really grow and to really find this place where they're able to understand that this recovery process is really about learning how to live in the world, learning how to work with other individuals, learning how to have difficult conversations, learning how to grow. And so this really allows individuals to learn how to be social and to work on interpersonal relationships and to not have to rely upon the wisdom of old that they grew up learning and that led them to their active addiction. And so they're able to kind of break outside of that and to learn a new way of life. Okay. One second here. All right, sorry about that. All right, so number 4, promote equity and ensure cultural competence. Prioritize fairness, inclusivity, cultural sensitivity, and housing practices. And so the kind of really the training and the culture of the individual recovery residents should focus on these things and ensuring individuals are being accepted into the home, and ensuring individuals are feeling comfortable in this inclusive environment. To me, there's nothing more beautiful than walking into an Oxford house and seeing a very diverse crowd of people, and they're all getting along and doing an amazing thing. They're participating in recovery together, and being able to set that as the culture and being able to work with individuals to be able to get them to see that maybe some of their old ideas are just kind of nonsense. And now in this new environment and this growth stage in their life where they're learning how to live life without the use of drugs and alcohol, they're able to kind of grow and mature um, and understand that uh, now that I live in this setting and I'm interacting with these individuals, I need to be conscious of that, and I need to be conscientious to them, regardless of where they come from, what they might look like, who they might like, and things of that nature. And so, just being able to um, have that environment and not only just have it and talk about it, but having that built in and having that culture there that is apparent when anybody walks in the door. It's so important. Being able for an individual that might feel uncomfortable in their own skin to walk in the door to a group of men or women, and they automatically feel welcomed regardless. That's tremendous and it's amazing, and that provides hope. All right, ensure quality, integrity, resident safety, and reject patient brokering. And so this is something that Florida has dealt with, and they've dealt with it well at this point, and they're ruling that out pretty much basically across the board. I'm sure there's still some bad actors out there and doing some shady stuff. Um, but Florida is at a point where there's very little of that. Um, it's something that is progressing throughout the state. I think a lot of the bad actors moved to other states when Florida started cracking down. And so you're seeing a lot of insanity in places like Arizona, Wyoming, and just places you wouldn't think it would be at. Um, and now they're dealing with what we've dealt with. And so it's pretty cool to see that they're able to look at what Florida has done, what California has done, and be able to kind of crack down much easier than what Florida has had to do, because Florida had to ride the bike without training wheels and to learn how to navigate this problem. Um, but with the implementation of FAR, with the chartering of Oxford houses, there is reassurances in place. There is quality checks in place. Um, but for those other states to be able to enable these practices, they have to look long and hard at what they have going on, and be able to identify the problems, to be able to rule out what's going on with the patient brokering, the fraudulent practices, making sure that there's a certifying body in place or a chartering Oxford House in place to make sure that the quality is being held to a high standard, and that individuals are living in recovery houses to actually recover instead of making somebody money. And so I think in the past, you'll see all of this go out the window for individuals that are solely concerned about making money. And so the unethical practices happen because of laziness and individuals just wanting to make money, and they care very little about the safety and security of the individuals that live in those homes. All right, so integrate co-occurring and trauma-informed approaches. And so I think we can all agree that many individuals uh, with substance use disorders may also have co-occurring disorders. And I think that's a pretty common theme. And so really having built into the recovery residents in their procedures, ways for individuals to take the medications that they need, take them how they're supposed to, uh, having that built in, having those expectations in place for those individuals, um, providing the support not only for the individuals that are dealing with substance use issues and his thoughts and going through the day-to-day of early recovery, but also for the individuals that might be dealing with some kind of mental health crisis, and being able to have um, specific best practices and specific guidelines in place for how to deal with those things, and do it in a way that's loving and informed, um, and to help those individuals grow, um, to where there's not um, to where they're not just feeling left out, and their issues aren't being heard, but that there's that support in place. All right, establish a clear operational definition. Um, so every single recovery housing organization should absolutely have the operation, the plan in place, the model, whatever they want to call it. It should be clear, it should be concise, it should make sense, not only to them as the operator and to their staff, but also to the members and the individuals that live in those houses, so that they understand what's supposed to be happening, but also like just collectively as the group, to where there's accountability in place, that there is this way for the individuals to know that I'm moving into this environment. This is what's going to be expected of me. This is how I am supposed to operate. And this is kind of uh, my path that I need to take. And so having that clearly outlined for those individuals, for that operator, um, is truly essential. Establish and share written policies, procedures, and resident expectations. So clearly document and communicate rules and expectations. And so we want to see, as a member or a individual getting out of treatment, moving into a recovery house, an expectation of what am I supposed to be doing here, procedures and how am I supposed to be doing things, and the written policies. And so I have it in black and white, and it's not just some arbitrary thing that was made up at the spur of the moment, um, but a clear thing that can be followed, that should be communicated one-on-one, directly to that individual as they're moving into the house or prior to that, and so that there's no room for, well, he said something completely different. It should be very clear and very on point, um, to where the individual knows what they're signing up for. Um, and it's not like an aspect where individuals like, well, I need to know what I should be doing or shouldn't be doing so that I know what I can get away with. It should be this uh, expectation that's set in place, to know what my framework for moving forward is, my framework for growth is. How am I going uh, to grow in my recovery? What's going to be expected of me, um, to where there's that forward momentum. The importance of certification, highlight the significance of certification for housing programs. And so, I mean, this is essential in this day and age. Um, the certification or the chartering with Oxford House, so we have a chartering process. It's so essential for individuals, to know that they're moving into a safe place, that they're going to live in an environment that has these standards and practices, that there's oversight, that there's accountability, and that it's not just this fly by night thing that I don't know what's going to happen to me tomorrow. Um, Certification process is essential to make sure that we continue to root out the bad actors in the state, and that those individuals don't want to operate here. All right, so promote the use of evidence-based practices. And if you read the best practices thing, that SAMHSA has put out, it really dives into what NAR has done and what Oxford House has done, and how they are recognized by SAMHSA as having evidence-based practices. but being able to just really work with individuals and making sure that your analyses are being done. Let me pull up my slide here. Um, I apologize. So the best practices of any recovery or any recovery residents should really be centered around what has been identified by SAMHSA in this, to where they know that they're working with something that has been identified to work. And it's not just something that somebody had this idea and now all of a sudden it is the basis for this program, but their idea comes from nothing that has been studied, nothing that has been worked on, and not been proven to work. But that really reliance upon the best practices as a backbone to be able to rely upon having the safety net for individuals and the safety net for the program, essentially, to make sure that they're actually helping people and they're actually doing it in a way that has been proven to be successful. Evaluate program effectiveness. This is something that every recovery residence operator, Oxford House, NAR, the NAR affiliate, should all do. Should all do on a continuous basis, whether it's through surveys and in-house visits and just working with individuals and filling out questionnaires and just truly sitting down and assessing the program's effectiveness. Are we truly helping people? And if the answer comes back as a resounding no, or even just a maybe, we don't really know, they should probably reassess and to work on probably looking at best practices to get to a point where there is clear-cut individuals that are being affected in a good way, that are being promoted into lifelong recovery, to show that the program truly has success. Because it's one thing to have a recovery home, it's another thing to actually truly help people and to encourage them in their recovery long term. Okay. So SAMHSA strongly recommends that recovery house operators, stakeholders, and state jurisdictions adopt the outlined best practices. And I think that goes without saying. I think that this is a beautiful framework for legislators to be able to sit down, especially in states that are struggling with a lot of these issues, to be able to sit down and to adopt these things and to put them into practice. Adoption of these practices is crucial for ensuring optimal support, safety, and quality of life for individuals in recovery housing. And all of this is true. All of this comes from places where there has been a tremendous amount of uh, unsuccessful recovery environments. That I wish that it was possible to just find a house, call it a recovery house, and everybody that moved in that house would automatically recover. But that's not how it works. There has to be so many things in place and so much accountability and oversight and support for individuals to truly want to be successful in their recovery. And then, even then, when you have the most successful recovery home in the world, even then, there's individuals that will still return to active use. We hope in those circumstances that individuals get some of the seeds implanted in them that will help them in their future recovery. But it is truly a devastating disease that we deal with. We deal with individuals that have this desire to escape and to get outside of themselves, and the only tool that they've known and the only tool that they've had legitimate access to has been drugs and alcohol. And so now when they're going to treatment, they're learning some actual tools that are going to help them change. And when they're going to recovery housing, those tools can actually be honed and worked on. And they might gain new tools, and they might really like strive in the recovery. But there's no magic pill, and recovery housing is just a way to help individuals grow, to provide that community support, so they can work on those interpersonal relationships, to feel comfortable in their own skin, to find a place of solitude and safety, that's not an invitation for them to drink and use again. That's not the old, past poor environment, but it's a new environment, where people can feel safe at the end of the day, and really be able to focus on their recovery and to grow as a human being. Implementing these best practices is key to fostering a more robust and effective recovery housing system. SAMHSA advocates for the vital role of recovery housing in supporting individuals with substance use and/or co-occurring mental health disorders. So this lays the foundation for a lifelong recovery journey. It's ethical, effective, and sound standards are emphasized for recovery housing programs, promoting a safe and healthy living environment. Access to community supports and recovery services is highlighted as significant for the advancement of individuals' recovery journeys in housing programs. Okay, and so that brings us to the conclusion of the SAMHSA best practices portion. Getting a little behind on time. So we'll just kind of keep going. Robert, if you want to kind of bring up the video, and just to kind of wrap up everything that SAMHSA has provided for us. It's an amazing thing. I think it should be talked about widely. I think that individuals that meet with legislators, that meet with state policy deciders, should, even if they don't fully understand it themselves, I think that everybody should read it. I think that this should be something that is passed out, and something that is, oh, wait a minute. SAMHSA had put out some stuff on that. Let me get this for you. And so for those instances, definitely be willing to pass this framework on, for individuals, for organizations, legislators that might have something to do with this, especially, and I'm sure probably nobody is from another state on here, but if you're in one of those states where they're really dealing with struggling issues, this is a beautiful way to help deal with those problems. Okay, Robert, you can go ahead and play the video.
Addiction, substance use disorder. It directly afflicts 10% of the population and has a devastating impact on the family, work, and social life of those who suffer from this chronic, progressive, and sometimes fatal disease. Now there is hope. Oxford House can help. In 1975, Paul Malloy and the men in his recovery home made a bold decision to take over the lease and operating responsibilities to prevent the home from closing its doors for good. Since that brave decision, the concept of Oxford House has expanded nationwide to over 3,000 large homes in nice neighborhoods. Oxford House exists with a primary purpose to provide housing and peer support for individuals seeking a safe, structured, and sober environment to start or continue their journey in recovery. Each house is established to be gender-specific with at least 6 adult beds. Members in the house operate democratically to keep the house clean and all bills current. Anyone in recovery is welcome to interview at an Oxford House, and once accepted by the current membership can stay as long as they wish, provided they pay their equal share of the household expenses, maintain their recovery, and do not engage in disruptive behavior. The social model within each house and local network of houses called chapters has been studied for over 30 years. A success rate of over 80% has led to the federal government recognizing the Oxford House model as an evidence-based program in practice. The cost savings to society is significant. Once up and running, each house is fully self-supporting. The challenge is opening houses fast enough in the communities they are needed. This is where you can help. 99 cents of every dollar goes directly to program costs, expanding and maintaining the network of Oxford houses. Our success is evident, even during a global pandemic. Saved lives, reunited families, healed communities. Join us and be part of the solution. Find out how you can help by visiting our website at www.oxfordhouse.org.
Thank you, Robert. Okay. Excuse me. All right, so just some statistics for you. So Oxford House nationwide is a peer-run, self-sustaining, substance-free housing. Peer support, recovery housing with proven success and time-tested evidence-based model. So the first Oxford House was opened in 1975 by a group of men that were living in a halfway house in Silver Spring, Maryland. The halfway house at the time, run by the county, was being shut down. They came in, told the individuals they had a certain amount of time to find a new place to live. Collectively, those individuals realized that they needed this halfway house environment in order to be successful, to not go back and drink again. And so they decided to devise a model that they could run themselves and they could do it themselves. And they really found out that they needed to do it in a way that was cost effective because they couldn't afford to pay for a counselor to come in. They couldn't afford to have a cook and they couldn't afford certain services. And so this Oxford House model came about because of this. Some very smart individuals, mainly Paul Malloy, and then Whit Holden still works for Oxford House, or co-founder. They were able to devise this system to where they could run themselves and maintain the accountability in a recovery environment to where individuals had a safe place to live, and they'd make sure that individuals weren't going to return to active use, and if they did, they'd be asked to leave, creating an environment that focused on the health and safety of the individuals that lived in the house. And that spurred on to what we have today with over 3,600 houses, over 29,000 beds across the country, 46 states and DC, and in 5 other countries as well. We have houses for men, women with children, and men and children. And I'm going to kind of run through this kind of quick, just to kind of maybe answer some of your questions. Hopefully we can get through it all pretty good. So Oxford House is in Florida as of today. So as of today, we're at 173. I did this slide about a month ago. So we'll just stick with that. At 168 houses, 1,523 beds, 209 women's beds, 346 women and children's beds, 939 men's beds, and 29 men and children's beds. And so the women and children, men and children are able to have a child live in the house with them. A parent can have their child up to the age of 12 live in the house with them. Houses are kind of set at being able to only house 1 to 2, in some circumstances, 3 children at a time. And so for those other individuals or for the other beds in that house, they would just be for this individual. This is our growth. We actually opened the first Oxford House 5 years ago tomorrow in the state of Florida. Woohoo. It's a pretty amazing thing to see our growth and where we're at today. I was part of opening that first house in Tallahassee. And it's amazing to see the growth and the lives that we've changed over the past 5 years. Member qualifications with withdrawal free, so they can't need to have gone to detox they need to go to detox first before they were to come to an Oxford House. But as long as they have completed a detox, they may interview for an Oxford House. So completion of medical detoxification, completion of inpatient treatment, reentry from Department of Corrections or county jail, referral through a 12-step, or even just word of mouth, and somebody's got the phone number and, hey, I need an Oxford House. And so really the main thing is withdrawal-free sobriety and a willingness to work a recovery program. And so willingness to work a recovery program, ability to pay equal share of expenses. And so again, with our democratic model, this self-supporting model, we have a financially self-supporting model as well. And so the house collectively pays the rent, the utilities, the house, they buy house supplies, Wi-Fi and cable and the phone bill, all of that themselves. And so with that, we're able to very effectively find nice houses and nice neighborhoods, but also keep it cost effective, and have an environment that is comfortable for individuals long term. And so all Oxford houses in the state have single bedrooms. It's a mix of single and double bedrooms. An individual might and usually will move into a double bedroom first. But as seniority goes, when the time comes up, they're able to move into a single bedroom. And we want to create this comfortable environment for individuals to stay long term, so that they will work on their recovery. And so they'll find that foundation in their recovery to be able to grow successfully and not feel like they're in a trapped environment, an environment where they feel like, oh, I just need to get out of here. We want them to feel grateful. We want them to feel safe. We want to have that therapeutic environment to where the individual is glad to be back home at the end of the day, after dealing with multiple issues that they might deal with in their early recovery. So it's a tremendous thing that we focus on. Becoming a member, so fill out an application, call for a house interview, show up on time or call, be open and honest during the interview process. Also, I always encourage people, and I think this goes back to the best practices. This is not only an interview for the members in that Oxford House to interview you, but it's an interview for you to interview them and to interview what the Oxford House is like. And so if this is an environment that you don't feel comfortable in, which it should be, I think that we do a tremendous job at creating that throughout the state, you might want to interview at a different house. So there's that process as well, and we invite that. Again, with the democratic basis foundation of Oxford House, there's an 80% acceptance vote required to be accepted. And then that new member that does get accepted is able to move in immediately. And they're able to move in if they're getting a treatment in a week or whatever, that's fine as well. These members do well in Oxford House: opioid use history, co-occurring, veterans, drug court participants, reentry from incarceration, chronic reoccurrence, medically assisted recovery participants. And I think Oxford House does a tremendous job across the board for any individual that would like to continue their recovery. Mainly for one amazing aspect is the democratic process, and that I have a voice and a say-so, and all of a sudden I'm not being told what to do by an individual, by an owner or a doctor. It's no longer that authority figure that is telling me I need to do something. It is my peer group holding me accountable. My peer group that is doing the same things I'm doing, that is being held accountable just like I am. And so you have that change in perspective. And a lot of people that have done very poorly with authority in the past are able to move into an Oxford House and do tremendous. So we have 9 traditions for success, and those are outlined in our house manual. And really it's about that foundation and the democracy. And so the house is democratically self-run. The house membership is responsible for all household expenses. The house must immediately expel any member who uses alcohol or drugs. And that's kind of immediate is the expulsion needs to take place. The individual doesn't necessarily need to leave immediately. If it's at night, if it's a difficult time and we're trying to help them get to treatment, that's fine. They can stay until we're able to help them figure out their next step. And that next step would help be facilitated within that house. Members receive peer support within the house, within those individual members. Accountability to not only follow the Oxford House guidelines, but accountability and recovery. It's fine that an individual is going to a certain amount of meetings and they have a sponsor and they're on a step and they're on paper progressing in their recovery. But now I have this peer group of individuals that are also working a recovery program. And now we're able to sit down and really talk about what an individual has going on. And is that individual being true? And are they truly progressing in their recovery? Or do we need to implement some more support and to more guidance to really help that individual progress in their recovery and to kind of get it, so to speak? Responsibility. And so Oxford House is divided into 6 different positions as far as the day-to-day running and maintaining of an Oxford House. You have a house president, a chore coordinator, a treasurer, secretary, a comptroller, and a housing services representative. And collectively, and with the other membership, if there's more than 6 individuals in the house, they're democratically able to run that house on a day-to-day basis. There's a house meeting done. It's a business meeting done weekly where we'll go through the finances of the house, the cleanliness of the house, individual recovery of the individuals that live in the house, and really get down to the nitty gritty on just every aspect of living in that Oxford House. Safety, stability. Again, nice houses, nice neighborhoods. We're not trying to put houses in poor income areas where it might be an invitation to start drinking and using again. We want to give them a good chance of success. And so again, you get that greater chance of success living in the Oxford House and having that kind of democratic foundation to guide. A few statistics. There were 2282 men's houses in the end of 2022. And this is the 2022 national profile. The 2023 national profile actually just came out. And I can get that to whoever, and maybe I can give it to Robert and he can send it out if anybody would like that. We definitely have some updated stats there. But 682 women's houses, 367 women and children's houses, 95 men and children's houses. There were a total of 28,034 beds with 19,637 for men and almost 8,400 for women. The average member age was 39, the youngest member being 17 and the oldest 85. Primary substance use before Oxford House, alcohol, methamphetamine, opioids, including prescription and illicit, cocaine, cannabis, prescription medication, hallucinogens, and inhalants. Homelessness and incarceration. 65% of members reported prior homelessness, and the average number of times members had been homeless was reported at 5. The report prior incarceration rate was 46.2%, and the average total months spent in jail or prison was 4.7 months. Employment and income, 76.8% of members were employed for wages and 6.5 reported disability, Social Security as their employment status. 35.3 of members reported a monthly income of $1,000 to $2,000. It's kind of the average, I think. Member recovery and experience, the average length of sobriety was 587 days. 73% of members reported being high school graduates, with 32% having some college education and 9.6 being college graduates. The importance of Oxford House to members' recovery was rated on a scale of 1 to 5 at an average of 4.7. So you can see the members' own description of their importance of Oxford House to the recovery was very high. The average length of stay was reported at 329.8 days, which is, again, we talk about we want to create that environment for those individuals to stay long term, to feel comfortable to stay long term, so that they can focus on that recovery and focus on that foundation so that when they leave, they have that foundation in place. SAMHSA's has recognized Oxford House as having evidence-based practices and programs and practices. The Oxford House model is a community-based approach to substance use disorder recovery that emphasizes peer support and mutual aid. The model involves individuals with a history of substance use disorder living together in a substance-free democratic home. Members of the house provide each other with social support, accountability, and mentoring in recovery. The Oxford House model has been evaluated through numerous studies and has been found to be effective in reducing substance use, increasing employment and income, and improving other aspects of social functioning. The NREPP has recognized the Oxford House model as an evidence-based practice for substance use disorder recovery. And so Oxford House has this just tremendous ability of creating community. So you have not only the house is there and is a tremendous way for individuals to gain a perspective and gain the ability to have those interpersonal relationships and learn how to have them. But it also kind of goes up from there, and there's a tremendous service structure in Oxford House. And so there's chapters all across the state, and a chapter is really comprised of members that form basically a board to be able to help provide support to the houses and be able to do trainings and guidance and have unity events, which we do a bunch of, and just be able to be this kind of arm that is always there to support the houses. And then there's a committee off of that we call our Housing Services Committee. And they're, again, there to really help focus in on trainings and making sure the houses are doing well with the house meetings and being able to maintain the guidelines with the membership in the houses. And then above the chapters is our state association. Again, basically another arm to be able to provide support and doing larger trainings, larger unity events, conventions and workshops, just amazing things. We actually have a workshop coming up in March where we're going to have 150, 100 some odd members across the state come together and participate in trainings, listen to recovery stories, do some fun things. It's going to be an amazing thing. And then we have our World Convention, which we're lucky enough to have here in Orlando in October. And it'll be a first time here in Florida. And it's just an amazing thing. You'll have 2,800 plus Oxford House members and alumni and staff come together to be able to share their experience, strength, and hope, and be able to teach on the Oxford House model and give guidance and support. It's an amazing thing to see. So Oxford House gives people recovering from substance use disorder and all backgrounds the best chance at long-term recovery. Oxford House saves millions of tax dollars nationwide. Oxford House expansion is possible in periods of both good and poor economics. Over 48 years of experience and backed by federal government as a best program in practice. All right, now into FAR. I do want to take a quick 5-minute break for anybody that would like to take a break, but I will be right back. Is that okay, Robert?
Yes, that's fine.
All right. I will be back at 11:30. Okay. Let me try to get through these real quick, and then we'll get into some of these questions. And so the NAR affiliate in Florida is FAR, the Florida. So it's actually, so NAR stands for National Alliance of Recovery Residents, and FAR is a Florida Association of Recovery Residences. So it was founded in 2011. Is dedicated to evaluating and monitoring standards-based recovery support services in community-based residential settings throughout Florida. FAR serves as the Florida affiliate of the National Alliance of Recovery Residences. Its philosophy, FAR supports recovery residence providers in delivering quality recovery-oriented housing opportunities in peer supportive environments, emphasizes the importance of encouraging and monitoring provider compliance with national standards for ensuring the right to recover in an atmosphere that meets special and basic needs for safety, dignity, and respect. Its intent to fairly certify Florida recovery residences voluntarily demonstrating compliance with the NAR standard and FAR Code of Ethics. FAR provides training for owners, managers, and staff of recovery residences to enhance and inform their delivery of quality services. Its commitment, FAR is committed to providing fair and impartial support and encouragement to recovery residents providers expressing a willingness to achieve compliance with the NAR standard and FAR Code of Ethics. Actively participates in academic research studies focused on recovery-oriented system of care, recovery management, and residents' personal development of recovery capital. And so we're going to get into the kind of the laws that Oxford House, FAR, recovery houses in general in the state of Florida, and NAR is the certifying body. NAR is over making sure that the certified recovery houses in the state, although it's voluntary, they're implementing and doing things according to FAR's Code of Ethics and NAR standard, and that they're not running off all willy-nilly doing what they want to do, or not doing anything. And so it's definitely good to have in place. First, we'll cover medication for opioid use disorder and recovery residences. So in NAR standards, medication for opioid use disorder is available as a tool in addiction recovery. Research indicates that medication for opioid use disorder, coupled with other support services, enhances engagement and outcomes. Legal rights for individuals that are on these medications. Recovery residences cannot deny admission based solely on medication use. And so this is a big one. And I think the terminology is very similar to this, or it's almost identical to what Florida is going to be putting into legislation or trying to be putting into legislation in the near future. Although this is a federal law, we can't discriminate against these individuals because of the federally approved drugs that they're on. There's still this kind of back and forth with a lot of recovery housing operators, whether they're certified or not, on being able to allow individuals on Suboxone or methadone or even Vivitrol, or only picking and choosing certain ones, or even some dictating the dosage limits that individuals are on. And so it's something that FAR is working very heavily on, that they're working with all of their operators, all their organizations to get in compliance with and to understand the need that we're dealing with an opioid epidemic, and that this is not a game, and that the homes really need to accept this and to embrace it and move forward. And so that's something that should be happening. There's the recovery house, or the recovery task force out of West Palm Beach, used to be the sober home task force. is really working on legislation, working with legislators to get that into law, to have that piece really dictated as a, even though again it's already in the law, it's already federally in the law, to making sure that the state puts it in there black and white to where people will actually follow. Referrals for medication users. If a recovery residence cannot accommodate certain medications, referrals should be made to an alternative facility. And so a reason in the NAR kind of literature is just a lack of pertinent staff or services. Naloxone availability and training. In my mind, you can't ever have enough naloxone this day and age. It really needs to be out there everywhere. Having it in recovery residence just makes sense, and making sure that individuals are supplied with it. And so I think that just is a common sense thing there. Certified recovery residents adhere to the NAR standard number 16. So that's really just identifying that they're providing a alcohol and illicit drug-free environment, but also factoring in the use of medications for opioid use disorder, and the use of medications for maybe co-occurring issues, things of that nature. And so just illicit drugs is what it's getting at. Provisions for secure drug storage and medication administration with accordance with prescriptions. And so the NAR houses, they do have standards and guidelines that really dictate how things should look like for medications, and that there's things in place to where there should be much less diversion and much less abuse of even prescribed medication. Okay, medication for opioid use disorder in Oxford houses. So all Oxford houses across the country accept individuals on medication for opioid use disorder, whether it's Suboxone, Methadone, Vivitrol, Subutex, Sublocade, all of them. We recognize that we're not doctors, that individuals, the members living in houses are not doctors, can't democratically tell somebody they need to lower their dosage or do something that a doctor should solely be in charge of. And so back in 2016, the Oxford House World Council really went through and decided that it should be across the board, all houses should be accepting of individuals on medications for opioid use disorder. I think even back then we realized the way that the country was headed with the opioid epidemic, and that there's really no reason to turn away from that. And, I mean, even today, there's currently over 70% of Oxford houses in Florida have at least one individual utilizing medication for opioid use disorder. There's probably quite a few that have many more than one person. And then even some of our staff, we have individuals, which is super beneficial, especially as we're training and working with houses to understand, and they might come from that old big book mindset to where, well, we can't have those individuals around us. That's not real recovery. Well, it is, and it's a new way in order to help save people's lives and to be able to get them into a point to where they're have a lifelong recovery, and to where they're no longer drinking or using drugs. And so it's something that we have embraced in Oxford House, and we've seen tremendous success with, and a lot of the kind of myths about bringing individuals on medications into Oxford houses were dispelled within the first weeks. Individuals are in charge of their own medication. They need to keep it in a locked box, but it is up to them in order to take. They need to take it as prescribed, and there is accountability with that. The individuals, they might be asked to do a med count in front of the other members of the house, but they're going to make sure that the individual is taking the medication as prescribed by their doctor. And we do a lot of trainings. Excuse me. We do a lot of like statewide trainings, regional trainings with multiple chapters, or even just chapter trainings, where we talk pretty extensively about why accepting people on medication for opioid use disorder is a good thing, and how to properly hold individuals accountable and to make sure that they're not diverting medication and doing it how the doctor wants them to do it. And this does go back to the best practice number 2 that SAMHSA identified, and really just individualize meeting people where they're at. So individuals have autonomy to choose housings that align with gender identity and supporting recovery, including medication for opioid use disorder. Interview process assesses environments, alignment with goals, including medication regimen. And again, that interview process should not be one-sided. It should not be the provider or the Democratic group, if it's an Oxford House, interviewing that individual. The individual should also be interviewing that provider or Oxford House. Clear expectations across the board. I think that we've kind of identified that expectations should be very clear in black and white. Residents define policies on medication for opioid use disorder, addressing medication use and relapse. Written policies empower informed decisions and ensure transparency. Referral process. Referrers consider individual situations, including medication needs, criteria, support level for medication use, staff training, and cultural acceptance. All right, so I'm not a lawyer, but I will do my best to explain the laws that are, there's a couple laws that really pertain to what we've talked about today. They talked about the individual kind of benefit and the state or the legislator and why they've put this into place for the state's benefit. All right, referral restrictions. So licensed service providers are prohibited from making referrals of patients to or accepting referrals from recovery residences unless the residents hold a valid certificate of compliance and is actively managed by a certified recovery residence administrator. And so again, that's FAR. So FAR does the certification. They make sure that there are certified recovery residence administrators in place, and that these licensed providers are actually licensed. And so that referral process, FAR makes sure that everything is done to where this law is met. Referrals between a licensed service provider and a recovery residence are allowed if the residence has no financial ties with the provider, is democratically run by residents with a charter from a Congress-recognized entity, and neither the residents nor its residents benefit from the referral, either directly or indirectly. And so this is where Oxford House fits in. Some might call it an exemption from certification. And so it basically allows service providers to refer directly to Oxford Houses, even though they do not have certification from FAR. And because Oxford House is got its own charter mechanism, because it's recognized by SAMHSA as having evidence-based practices, this has been allowed and put into law to be able to allow Oxford House to operate in conjunction with FAR without having to be certified by FAR. Another exception includes licensed providers under contract with the managing entity. That I don't know too much about. I know that this is something that is really kind of vague, and I don't know that there's any providers that actually do this. I could be wrong, but I believe pretty much any provider that would fit in this category would be pushed by the managing entity to get certified by FAR. Referral to or from recovery residences, substance use restrictions. Referrals are prohibited if the recovery residence allows the use of substances by individuals other than the prescribed patient. Again, it's a recovery environment. Definition of referral. This section defines a referral broadly, encompassing any information exchanged about a patient or recovery residence. And so it's pretty broad. Penalties, willful violations result in a first-degree misdemeanor, and fines of $1,000 per occurrence may be imposed on violators. Again, I think that'd be pointed at the provider as an organization, not an individual. Repeat violations can lead to license suspension or revocation. Record keeping. Licensed service providers must keep records of referrals as prescribed by the department. Discretionary referral. This section clarifies that there's no obligation for a licensed service provider to refer or accept referrals from recovery residences. So the voluntary certification of recovery residences acknowledges the higher success rate of sobriety for those in recovery residences, recognizes a state interest in protecting vulnerable individuals in need of housing. So the department to approve a credentialing entity by December 1st of 2015, and that is FAR. Entity responsible, establish certification requirements, administer application, certification, and disciplinary processes, conduct training and develop a code of ethics, set application, inspection, and renewal fees not exceeding $100. Recovery residents to submit a comprehensive policy and procedure manual, rules for residents, intake procedures, and compliance policies. Certification process. Certified recovery residents must be actively managed by a certified recovery residence administrator. And so that's a process for a new or emerging recovery house. They need to have staff that are trained as recovery residence administrators that are certified by the Florida Certification Board. On-site inspection upon receiving a complete application. Background screening for owners, directors, and CFOs. Certificate of compliance issued upon approval, valid for 1 year, subject to renewal. Monitoring and compliance. Annual on-site inspections for continuing compliance. Credentialing entity may suspend or revoke certification for non-compliance or failure to address deficiencies. Immediate reporting and replacement of the certified recovery residence administrator. Revocation for false information provided. Reviewable decisions by the credentialing entity can be appealed to the department. Public advertisement, misdemeanor for advertising as a certified recovery residence without obtaining a certificate of compliance. Visitation policies, guidelines for allowing minor children to visit parents in recovery residences. Discharge policies, certified recovery residences with an approved discharge policy can discharge or transfer residents under specific circumstances, prioritizing resident welfare and safety. Okay, I know, Robert, we have a bunch of questions, and I just want to try to get through as many as I can.
Sure thing. I've been keeping track of the questions. I will go in order as I have them and watch the chat for additional questions. But the first one I have seen is, are recovery residences required to be ADA compliant to accommodate ADA recognized disabilities?
That I don't really know. I think that it would, yeah. I mean, in a circumstance where, I don't know. I know that Oxford House is classified as a single family home, and protected as such. It might be different for the level 2 through 4, and I would assume it is. I'd say in my shoes that for Oxford House, whenever we have an individual that is needing some accommodations, we try to make that happen. And if we're unable to, we try to find a facility or a place for that individual to go that would be an alternate option. that is something that I will definitely look into, though.
Got it. How are recovery residences being funded and who is overseeing them in terms of standards and safety?
So they're funded, I'd say mainly through the individuals that live there that pay a fee. The, there's probably a lot that are tied in with a treatment facility that might have a reduced cost to really just try to maintain an individual in treatment services. I think that a lot of the level 4 houses, recovery residences, are able to bill insurance for that. In Oxford House, all the houses are self-supporting financially. And then who's over those? Oxford houses collectively maintain democratically the houses themselves with much guidance and support from the OHI staff. For all of the FAR recovery houses, they're overseen by FAR and made sure to be in compliance by FAR. For all of the uncertified houses, it's kind of the Wild West. And so there's really nobody to make sure. And so I don't think that we're dealing with a huge amount of those like we have in the past, but there are some out there. And I don't know, I'm sure there's good ones, but there's also probably some bad actors. And so I don't really know what that looks like.
Got it. Can an 18-year-old be eligible for Oxford House? Are there any age restrictions?
Yes, so for Oxford House, absolutely. We even will allow 17-year-olds as long as they have been emancipated or they have been approved with a letter from their family. And usually that's a phone call and a longer discussion of what that looks like. And I'd imagine 18 is fine again for all of the FAR certified recovery houses as well.
Got it. How is it ensured that residents are drug or substance free if there is no staff? Does someone come in and do urinalysis tests?
Yeah, so the houses will do your analyses themselves. And in Oxford House, we really focus on behaviors. We really train continuously on the focus on behavior. And so our kind of mindset is we want to pinpoint individual behavior. We want to get to know individuals well enough to where if they're acting out of sorts, we can sit down and have a conversation, and we will sit down and have a conversation. And that our hope is that we will stop a relapse before it occurs, because there's many things that happens in the relapse process before somebody actually picks up drugs or alcohol. And so for an Oxford House, even though there's not a staff member dictating that this person needs to be drug tested, we teach how to deal with that, and we teach it in a very effective way. And we've been doing it effectively since 1975.
Awesome, thank you. How does it work with rooms and children? Do children room with their parents or do they room with other children?
That's a good question. Yeah, so all children will room in a single room with their parent. It's usually a room large enough to have uh, enough space for not only that individual member to have a good sized bed, but for the child to have a good sized bed as well. And so it's just the parent and child.
Got it. Are background checks conducted on residents, particularly in houses with children?
No, they're not. Individuals are interviewed. They're asked many questions. But there is not a background check done. If there is reasonable suspicion of something that would be a determining factor of not allowing an individual to live in an Oxford House, that would be solved out. But Oxford Houses do not allow individuals, at least in the state of Florida, to have registrable sex offenses or registrable arson offenses. And so that's again, the Oxford House model being democratically run, being that single family home environment. It's up to the individuals that live in that house to choose to accept somebody or not.
Got it. How self-sufficient does a resident need to be? Do they need their own vehicle? Are there employment requirements such as full-time? What is the monthly cost roughly?
Yeah, so they do not need to have a vehicle. We try very hardly to put all Oxford houses close to public transportations. There's a couple cities we're in the state of Florida that don't have public transportation, but we work with other organizations to do bikes, and we try to put them by local jobs and meetings and things of that nature. We do that very effectively, and so they do not need to have their own vehicle. Basically, all members work full time. It is up to them where they want to work. They don't have to work though. If they choose not to, if they're on Social Security, if they're retired, if they're going to school. So if they're retired or on disability, we just ask that they get some kind of volunteer job so that they're not isolating in the house, spending all their time becoming depressed, which is what isolation leads to. And so we want them to get out and really to experience the community and to do that. They don't have to do that all day, every day, but we do require them to get out. 15 or so hours per week is, I think, is the kind of generally accepted practice. Um, there was one more part to that question. What was it?
Um, I think you hit all the points. A person asked about
Oh, the average
employment
month.
requirements and then transportation, and then what is the cost?
Yeah, average monthly cost is, it varies from Pensacola to Miami. Um, so I mean, it just depends, but it's anywhere from $135 per week to up to $250 per week in Miami, and anywhere in between that. And so I think like in Orlando, it's all the houses are about $175 per week, and so that would translate to about $800 per month.
Got it. I know that you mentioned early on that recovery residences have largely moved away from being faith-based, but are there still faith-specific houses?
Yeah, absolutely. And there's some really good ones too. And there's some that are FAR certified, and so oh, I did mean to mention, if you get on FAR's website, it was acting funny the other day. That's why I didn't include that in the slideshow. Um, but they have a list of all of their houses and contacts to be able to contact them. So it's FAR, FARR online.org. And then, but on the flip side, Oxford House, all of our Oxford houses are listed on our national vacancy website, which is www.oxfordvacancies.com.
Got it. Looks like we have probably time for one more question here. One person asked, Oxford House states an 80% recovery rate. What is this based on? And are clients followed after they leave and documented for continuing in their sobriety?
Yeah, so in that circumstance where the study was done, they were. DePaul University has done studies and did a study that tracked uh, a pretty good amount of people as they lived in Oxford House and then as they transitioned out of Oxford House. And so they found if you had lived in an Oxford House for 12 months or more, which is our recommendation, that again, we want people to stay long term to focus on the recovery. But if you stay 12 months or more, when you leave Oxford House, you have a 87% rate of success in maintaining long-term sobriety up to 3 years out. And so that's as far as that study went. And so, yeah, it's the success long term. We don't continuously follow all residents. We have over 30,000 beds now. It'd be nearly impossible to do that. But it's there. I mean, people that stay long term, that stay those 12 months or longer, have tremendous success rates. Even staying at 6 months or greater, there's over a 65% success rate for those 3 year and longer. And so, yeah, it's about staying, and it's about working on recovery, and finding that really that true success. The individuals that stay for a month might not have nearly as high success rates, but that's why we really create an environment for people to want to stay long term.
All right, thank you so much, Michael. I'm going to switch us over to the conclusion. I know, ladies and gentlemen, we did not get to every single question, but I will put up Michael's contact information here momentarily if you want to take down his email and follow up with any questions about recovery residences. He would be the person to ask. His email on the screen now is michael.mckeogh@oxfordhouse.org. So make sure you take that down, or you can email me and we'll forward it over to him if you still have questions. But Michael, I want to take a moment to thank you for the time that you put into today's webinar and all the valuable information you shared with us. It looks like we had a lot of participation. People are very interested in the recovery residences process. So I really appreciate your time and sharing this information with us. Everyone, I am going to drop the survey in the chat. Please remember that when I close this webinar here momentarily, your web browser will come up and say that WebEx is trying to redirect you to a website. Do not close out of that. That is not spam. That is WebEx trying to redirect you to the survey automatically. Once you access the survey, you will be prompted to sign in or register to complete the evaluation. You can register on our website as a visitor at no cost. You may do so by clicking haven't registered yet. You must use the same email address you used when you registered for today's webinar when you set up your profile in our system. That is the only way to connect your attendance in today's webinar and your profile with the survey completion. So make sure to use the same email address. After you register or sign in, you will be directed onward to the evaluation. You'll get a second opportunity to complete the evaluation through a follow-up email later today. For CEs to be reported to CE Broker for Florida licensed healthcare practitioners, you must provide an accurate Florida Department of Health license prefix and number the first time you register. If you need to add or update your license number, you may do so by logging in and clicking Edit on the professional information section of your profile. Please keep in mind that the evaluation will close at the end of the day on Tuesday, March 5th, 2024. If you experience difficulty logging into your account or accessing the survey, please contact us either by filling out a contact form on our website as shown on the screen, or by sending an email to training@floridabha.org before the evaluation closes on March 5th, 2024. Please keep in mind that we do not email statements of credit. Instead, after we verify attendance and completion of the evaluation, a statement of credit will be posted as a journal entry on your profile within 30 business days after the evaluation closes. As a reminder, the recording and materials used in today's presentation will be available on the FADA website within 30 business days. To access the recording and PowerPoint, please visit www.fada.org, navigate to the Resource Center, and click on the training library as shown on the screen. Thank you all for participating in today's webinar. Thank you again, Michael, for your time and for your information. We'd also like to recognize and thank the Florida Department of Children and Families for funding today's education. Have a great day, everyone, and please hold for the evaluation.